So let's start. It's 3 minutes past the hour. Welcome everybody to the PHEMS meetup. This is the last session of our autumn series, but do not worry. Our meetups will continue with the winter series and spring series and everything. So we've had 3 previous meetups. Started with the PHEMS overview on the pediatric health data space, which is our goal. Then about the federated data networks, then the design of the pediatric health data space. And today we are presented the clinical use case of benchmarking in cardiology operations. Don't worry if you missed the previous meetups, so they are available on our YouTube channel, where this presentation also will be shared afterwards. So we will start with first the presentation, and then later there will be an interactive Q&A session when all of you will be also granted an access to open your mic and camera. That part will not be recorded, so it's only the presentation part that will be then shared. Then if we got the next slide, please. So our goal, just as a recap, is to enable safe data sharing across borders in pediatrics, because pediatrics is an area which is characterized by small numbers of complex patients in a country. So if we want to create any type of scientific evidence or assess new medications or develop new algorithms, we need to somehow be able to collaborate on data, even cross-border. And today's topic is very much on the fact that many countries have only 1 or 2 children's hospitals that do the most demanding pediatric care, and they're benchmarking to improve performance and efficiency and treatment quality is difficult unless you can go cross-border. So our consortium consists of 14 partners. We're awarded a Horizon Europe grant of 7 million euros, and the project is working for 3 years. And we are aiming to build a pediatric health data space that remains in operation with technical platform and a governance structure, so that we can really continue and scale the collaboration on pediatric health data. The 6 pediatric hospitals that are involved in the project are the origin of pediatric health data space, but later on it will be open to join also by other hospitals and also by other data users. So then to our today's speech, Andrew Taylor, Director of Innovation at Gauche, will be sharing about the cardiac benchmarking use case that is being done in PHEMS. He's also Professor of Cardiovascular Imaging in the University College of London and has been a Director of Innovation at Great Ormond Street for many years. And he's one of the leading characters of PHEMS project, and truly pleasure and privilege to work with Andrew. And now I'll give the floor to him to share about the benchmarking use case that we're working on. So Andrew, the floor is yours.
Thank you very much. Just to check that you can hear me.
Yeah, we hear you loud and clear.
Perfect, Pekka. Thank you very much. Thank you very much for that introduction. Welcome everybody, and good afternoon. As ever, it's actually I've been in many EU collaborations over the years, and this is really under the Hus leadership. It's an excellent partnership, and it's a great one to be part of. So you've heard lots in the previous meetings about how we want to set up, particularly around our federated analytics. But one of the things is actually how is that clinically relevant? And we're going to touch today on what we've been trying to do in what is called use case 1, which is around benchmarking. So I think the first thing that we need to ask is actually, can we drive, or how can we drive safe clinical care, monitor our performance, but also importantly make sure that we improve the care that we provide to our patients? And the data is absolutely crucial to this. And actually, probably over the last decade or so in my own organization, and we're going to talk about cardiology, we have had a weekly mortality and morbidity or clinical governance meeting. And at that meeting, we have discussed what has gone really well that week, what didn't go so well, and what we might need to change. And what has underpinned that has been having the data at your fingertips to have those conversations. And in particular, about those areas where things might not go so well as we planned and where complications happen. What I would say is, and this is an interesting bit about benchmarking, is probably for 95% of the patients who go through, everything works perfectly well. And weirdly, we don't really focus on that. So there's something we need to do around that as well. So the way I believe that you do this is by being as honest and transparent as possible. And one of the ways to do this is through benchmarking. So why might we consider this from a national perspective? So we might want to foster collaborations for the benefit of our patients, not for our organisations. To better measure the quality of the care that we deliver. Often to establish best in class. So what can we learn from somebody who does this really well so that we can improve our own performance? And I guess what is super important about this, it's for improvement and not for our hospital rankings. This is not about how good I am as a hospital. It's about actually every hospital will do something really well. How can we benefit from all of those things that people do really well to improve ourselves? So is there any evidence that this makes sense? Well, this makes a difference. There's quite a lot. And actually, I would argue in our own case, though, when we initially started presenting data, and in particular about complications, it is interesting how people respond to that. And I'll touch on that in a second. But ultimately, I think by being honest, by being transparent, by dealing with issues and taking them forward and dealing with the systems problems, you can really use the data to improve the care that we provide. And there's lots of evidence that that is the case. And I think, just to summarize, I think the evidence that's out there really does suggest that the outcomes can drive safe clinical practice, excellence, and clearly improve patient experience. Some buts though. So I think there's always anxiety about sharing data. Will we look bad? Our patient population is slightly different to yours. We deal with more complex patients. Our results might not be as good, that sort of thing. Are we measuring the same thing? I measure this for central line infection, but you measure this. How are we going to align those? And I think we can spend an awful lot of time doing that. I think one of the conversations we had very early on with Pekka is we might not measure exactly the same thing, but if there is a big difference, and we in our own organisation then change, we've got something to monitor, because what we're measuring can then be used to see if we've made an improvement. Do we have the data, and is it any good? So that is a very important, and you'll have heard that in the 3 previous presentations about how we align our data. And then how do we share that data and the governance around that, etc., so that we're keeping in mind all of those privacies that we want to make sure from our patient's perspective. So the way we feel, or I feel, to do that is actually by having a no blame culture. I have to say, when you're in a meeting and actually something has not gone right, whoever is potentially at the sharp end of that conversation will always feel some sort of blame. It's just human nature. But the most important thing is that we use those things that go right or go wrong to create a clear culture of learning and improvement to drive things forward. So what about some examples? So in the UK, for many years now, we have reported the 10 or so congenital cardiac centres in the UK have reported national benchmarking. This is predominantly around activity and in particular around 30-day mortality. So here you can see in the 2023, the number of operations and procedures that have happened, how much of an increase that was from the previous year, but certainly fewer than pre-COVID, whether the reductions that there have been in surgical procedures, and actually overall excellence of 30-day survivals for these patients. It also tells us something about how many patients are now having a fetal investigation, and it's beginning to look at complications and actually seeing that those procedures are quite, or the way we measure complications is quite varied across sites. One of the things that people have been able to do around a relatively or around a very well-defined risk model is actually look at the complexity in each hospital and therefore predict for each hospital what the survival rate should be, with knowing what the patients that hospital operates on. And as you can see across the UK, actually we get a kind of number as to where we should be. The hospitals across the UK are doing really well with those numbers. 3 or 4 of them are really above, and one's really doing very well. So much above the related to that 30-day mortality, much above that survival that we would be expecting. So that's really good news. So we know we're doing well there. But again, what we now need to do is to get into some of those complications, to what are the neurological events we have, so on and so forth. There's also examples across the US. with STC public reporting and other examples in Europe. So I think cardiology in particular has had a very good background of coming together and using benchmarking pediatric cardiology to drive many of these things forward. So lots of experience with this. But there are some current challenges. So most of these are all manual. So you'll get sent an Excel spreadsheet as an organization, and for each of your patients or your patient group cohort, you will fill in that Excel spreadsheet. So you've got people entering data. So it's a high effort required to do that for manual data. You've got to scour through, if you've got an electronic patient record or maybe still on paper, you've got to scour through that. And that's historically what we would have done. There can be inconsistencies in that data quality, and there are issues then around missing standards, the source of data and the indicators. And actually, it's hugely time consuming, prone to human errors, and therefore is inconsistent and probably not scalable. Having said that, I think there are about 17 pediatric hospitals that provide data within the US, and that system works well. And actually, if a system's working well, there are some bits of why you might want to change it. But I think what we're really focusing on FEMS is how can we automate some of these processes. So the two areas I'm going to touch on are cardiac benchmarking, and then something that has come out of we interact with the European Children's Hospital Organization, but something that's come from their CEOs, which is the question, can FEMS or the FEMS hospitals actually begin to address some other areas more broadly around hospital benchmarking? And I'll just touch on those. So cardiology patient benchmarking. So in this, we basically took our original view of the world of the stuff that we present. So we present every week something around patient safety. So we look at line infections, serious incidents, surgical site infections, and drug errors. We look at those things that might indicate low cardiac output. So if you've followed surgery, you've had ECMO, you've had renal replacement treatments, you've had necrotizing enterocolitis, or you've needed CPR. So again, if those things are happening, that might not be perfect, or it's clearly not necessarily great for our patients. Neurological complications, if you've had a normal EEG, seizure, an infarct, or a bleed. And then surgical complications, so whether there was a bleed that needed to go back to be reoperated on, phrenic palsy and re-exploration, and clearly also mortality. And historically, we've had a dashboard that looks like this. So in this particular instance, it would be there's 26 days since we've had a line infection. And my dream, as it were, would be to have something that says, actually, this is what the other 3 hospitals are achieving on this dashboard across Europe. So again, that sense check of where you are and actually where you might be able to make improvements, as an example. And this is just an example around a operation here called the Norwood procedure for a it's the first phase for children who've had hyperplastic left heart syndrome, so very complex congenital heart disease, probably one of the highest risks for mortality around surgery, and certainly one of the most complex surgeries. And this is our experience a decade ago around the length of stay in ICU. And what we've shown here is the particular patient we're looking at that week, and the questions that we would then raise are, why has that patient stayed longer than has been the average as a single centre? So what we're trying to do here across Barcelona Children's, ourselves, Hus and Sophia Erasmus, is can we create a very similar data set that is organized in the same way, so we've got the same ontology, and then without sharing the data between us but using federated analytics, then look to create dashboards that will compare our outcomes across these 4 hospitals. That then works in a continual iterative process where we look to build that, and you feed back into your model. So if one hospital's got a really good or really low central line infection rate, what quality package does that hospital use that makes that happen? And how do the other 3 hospitals learn to make that? And then we have this continuous improvement as we go through. So this process has really been, it's really about working with your clinical teams to understand what the case and the problem is. And so actually, this is relatively straightforward in the cardiac world, in that people have been trying to benchmark in this way for many, many years. Lots of good examples out there, but as I've alluded to, not automatic. So you've got to have that stakeholder alignment and a team that's going to make that work. You need to identify all of the data that you want. So the process that we went through, we had that dashboard. What is the data required to answer those questions across the 4 hospitals? Could everybody do that? And for about 90% of the data that we needed across the 4 hospitals, we believe that we had access to that data. Your next phase of this is clearly you've got to make sure around approvals and compliance. So we've done that through ethical approvals for all of this. As we work forward with the PHEMS project, and particularly with the pediatric health data space, we want to make that clearly rigorous, but as easy and as seamless as possible. So that is part of what we've done. We've then collected that data, and then it's about standardization, and we've used OMOP as our common data dictionary in this particular, or our ontology in this particular case, partly because of the investment that the EU has clearly made through the Eden project. And for our teams now, we're probably about 80% of the data that we now want, and probably about 95% for this particular use case is now in that form. So we now know that we're talking about the same thing. When I say creatinine, it means that who says the same thing for creatinine, for example. We then want to develop the analytic queries and the dashboard, which is a process we're now under. You then want to deploy that. And then I think you need a phase where once you've deployed, you have to look at the data, because there still may be issues with the data, which might be very obvious, or some of the data may be explainable, and some of those differences may not be related to quality. And that is a very important part of the process, because it may mean we need to do a further iteration before we start using these benchmarking tools to guide our practice. So though we've not got our completely automated process up, because we had our ethical approval, we knew where all the data was. I asked the data teams in a recent presentation where and this has been done manually, so not what we want to do, but at least all the data's there, is to basically look at just to see how we could query that. So here we've chosen length of stay. So this is in annual data. We've done it over a 5-year period. I'm just going to show you some of this, but around atrial septal defect repair. So an operation that is incredible, that we would consider as really straightforward now from a technical perspective. Clearly, any operation for a patient is daunting, but would easily have a mortality of way below 1% for most organisations. Tetralogy of fallow and coarctation of the repair, again, really procedures that we would be delivering incredibly well in our organisations, up to something more complex, so the arterial switch operation for transposition of the great arteries, and then, as I've alluded to already, the Norwood operation. And we also looked at transplant data. So what did we see? So this is 4 hospitals. Interestingly, when we presented the first time, everybody wants to know which hospital they are. I have no idea, so that's really good. But this is for atrial septal defect repair. So if you look at that, there's some variation across the years, but ultimately we're probably looking at a length of stay overall of about 4 days in hospital. However, we can see that Turquoise Hospital probably has a length of stay of about 7 days. There may be some reasons for that, but that's probably worth exploring. Because actually, if that hospital were able to follow whatever has been happening in the other hospitals, and you could bring your length of stay down by a couple of days, that probably is better patient care because you're in hospital less. But also from a hospital perspective, you've got 2 bed days. We know the pressure on our hospitals to get patients through. You've suddenly got 2 bed days that are free. And so that could help you potentially with efficiency and offering your treatments to more patients. So that sort of thing. And I know from a previous example in the US where this happened, when there was a difference, actually the reason that was happening in one hospital was that the patients were extubated, so the tube taken out to ventilate patients was removed immediately after the surgery, so on table, and then the patient went to the intensive care unit. In the other hospital, that wasn't happening, so the tube was staying in. That's all good clinical practice. There's no difference in those practices to a degree. But clearly, if you reach the intensive care with your tube down, you're probably going to wait a day or 2 before that tube is taken out. That's just the nature of it. And that's maybe where some of these extra days come in. So that's a really interesting thing to look at. Here, this is simple tetralogy of fallow. Note that and I'll call it this in the broad sense, the outlier initially here is a different hospital now. And actually, if you look at 23-24, then the length of stay for this particular procedure is about 10 days. And all of the hospitals are about that. But something interesting has happened with our Green Hospital over the years, and they've made a change over the last 5 years. What was it that changed? Really interesting to understand what those things were, and could that be applicable in another area? So that's another, again. And finally, for hyperblasts, notice here, a different hospital looks like they're a bit of an outlier. Now, I'd be very careful here. These are very small numbers that we're looking at. But actually, this is now 40 to 80 days range here. If you could save that amount of time, then again, the options for you to be able to get more patients through are really quite exciting. However, there may be a very good reason, because these patients actually often have multiple stages of operation. They have an operation at 4 days and then an operation at 3 months. In many hospitals, the patient will stay between those two, and that might be what happens in the pale pink hospital here. In some hospitals, though, they'll go home, but they're monitored really closely, often as what we call as fragile cardiac patients. It would be really interesting for these things just to compare complications rates and so on and so forth. Maybe keeping these children in hospital actually is beneficial to them. So again, it opens up a difference between our hospitals that is worth exploring, that then could help with how we take things forward and treat in the future. So just we just did this as a query that we put out there, had a look at the data, and we can clearly see that there are differences between the organizations that are taking part. The other thing we looked at then were some probably slightly mundane things, but again, tell us lots about our hospitals. I'll try and show something that is quite interesting around the number of surgical procedures and the number of cardiac catheterizations we might be doing. So I only have 3 of the hospitals here. We can see a split between bypass and non-bypass. This will reflect the size of those organizations in different regions. But there's a really interesting, this is the surgical procedures, and this is the catheter procedures. And what you can really see if you look at hospitals 1 and 4 is that though the overall total procedures is probably about the same, but there are more catheter interventions happening. I'll just flick back between those 2 slides. More catheter interventions happening in hospital 1. That actually might be a really good thing, because we might be carrying out less invasive procedures. I could potentially pick something like the atrial septal defects we've had. You could operate on those patients or do a catheter procedure. Again, it immediately gives, if that is the difference in practice, it gives us an ability to compare between those practices, look at the pros and cons, and then theoretically see how we might change practice going forward. So again, just from asking one simple question, we have a difference between our organizations that would be interesting to explore further. Similarly, we looked at total number of procedures for conditions. Again, this is why I think data check is important. I look at what you'll see on the left screen there in that orange where it says ASD, so that's ASD repairs. Hospital 1, that looks a very low number. The rest are about the same. Why is that the case? What you'll also note, this is only surgeries. That was the hospital that had lots of catheter interventions. Maybe if I add them in, that number will come up. So that's interesting. Arterial switch operations, complex operation, I kind of expect those sorts of numbers given the size of the hospitals. And then finally, this rare procedure, which is called the Norwood operation. What that instantaneously shows you, though, is even if the hospital that's doing the most operations there, which is about 11 or 12 a year, that's not really much to glean any research about, is it? Whereas we could easily double, maybe triple the number of patients to begin to look at getting research insights by bringing the data together. And as Pekka alluded to right at the start, that's clearly one of the aims. But just again, by looking at this data, we can show that we can begin to achieve that. And this is just with 4 hospitals. If we could have the 30 or so congenital cardiac centres across Europe actually contributing to something like this, that would be a real opportunity for these patients and to develop research and improvements and innovations going forward. We did ask about these. I'm not going to show these data, and that's partly because I think that we haven't done a final review of all those data, and it's very, very important that we understand, particularly things that are of great significance, your 30-day mortality, so on and so forth. Make sure we've measured it correctly before we report some of these things. But those are all data that we now have, and we can now look at number of reoperations, those patients that go on ECMO, unplanned readmissions to the intensive care, and actually whether you had an unplanned hospital readmission. So all important things. As ever, if you can get your operation right first time without any complications, we know that is great for the patient and great for the hospital system, because we know that those patients kind of fly through the system. Whereas actually, if there are these small complications, they can really hamper that and also hamper the flow through our hospitals. So just really as a summary, we kicked this off clearly October last year. We've had our kickoff meetings. We finalized the data that we wanted because we had a very good idea of the sort of data that we needed from what we've been doing at our own hospital. So to a degree, we all agreed upon that. We've then finalized that data availability. So within all of our catalogues, we've finalised our ethics permits in October, and we're beginning to finalise our OMOP alignment. I think for the cardiac use case, we're very, very close to being. We're at the 95% for our other two UK use cases where some of the data is not necessarily aligned with OMAP as it currently was. We're still working on that. So huge amount of process from the team. So just very quickly, and this will be very quick, I just go through hospital benchmarking. So this is really about operational teams and the sort of information they're interested in. And so in June last year, we went to the ECHO CEOs and said, actually, what would you like to see in something that provides hospital benchmarking? And they were interested in markers of quality across the hospital, what was happening with workforce, what was happening to patient flow through the hospital, so those hospitalizations, what was happening to the finance, and what were things that we might be able to measure around green sustainability. I'm just going to show you a snapshot from each of those. So the quality things, many of the things we've just talked about, so length of stay, average pre-op length of stay, 30-day mortality, central line infection, so on and so forth. So things that we're very used to. From a workforce perspective, it was around just the number of people that you had, what was their age profile, around the allied healthcare professionals, the nurses, the doctors, and the managers. What were their sort of production indicators? Were we able to see how long people stayed, new people stayed in the organization as a kind of indicator? What would staff satisfaction look like, and so on and so forth? So again, trying to get some feel, because we know that workforce is such a big issue for all of us, and how do we develop the pathways that mean that we attract people into healthcare, but also keep them within healthcare, because it's clearly a hard job and something that we've seen drop off in people wanting to apply for. Hospitalization, so again, just very basic things. How many hospitals you got in your bed? How many are ICU? How does your HDU work? What are your day cases? How many emergency beds have you got? So on and so forth. So very things that describe your hospital and how your hospital works. From a finance perspective, all the things that you'd expect around the costs, the treated patients, what might be your education budget, what might be your research budget. Again, just to judge where you sit, and possibly in those conversations one needs to have either with local or national government, useful to say how other hospitals deal with these things across Europe. And then finally around green sustainability, whether around waste, recycling, laundry, food, pharmaceutical waste, and carbon footprint. So interestingly, things I think lots of hospitals have data on, but where does that data sit? And I think with all of this, so that we've had a look at as teams across the 4 centres. 3 of the centres feel that some of this data is relatively easy to get. It doesn't sit in many of our electronic patient records as we currently have them, and so we need to look at other records, but actually it's about directing that data and then being able to use that. And so over the next 6 months, we'll see how far we can get for a couple of these indicators in each of these categories. So in conclusion, I think it's not easy to do some of this stuff, but it's important, and there are anxieties about sharing. And fundamentally, I think it's a very human thing of, am I going to look bad, if I'm completely honest? But actually, that's not what this is about. This is, I've never seen, and as I've shown in my examples, I think everybody has strengths, and actually it's how we utilize those strengths to make us all better. So I think that's really, really, really important. I think there are clear patient benefits, and we can clearly drive ongoing quality improvements. I think automating the process would be useful. As you can see here, there is a lot of upfront work to align everything. My gut sense of having done this locally for other areas other than cardiac is once you've done it once, it does become much easier, because actually most of the data you want to find is similar for similar use cases. But that first upfront time, as you can see, it's taken us about a year to sort all of that out. That does take time. But once you've done that, then these processes become much more automated, and therefore I think easier for sharing. And then the other bit of this is I think they do then create that ability for scalability and sustainability. And I guess what we're all after in areas where we deal with rare disease is, can we begin to amalgamate or even if it's not the data sets per se coming together, but the understanding from those data sets, so that we can begin to change some of the really difficult diseases that we deal with in pediatric practice. Particularly the last half of this, I would just really like to thank the key data people from each of the centres. So Lydia, Nicholas, Roger and Brian, who really at very short notice got some of that data out. And all they said to me was, please let it be automated, Andrew, because this is a pain. So that is, again, I think a good advertisement for the process that we're trying to do, because I think it can be really difficult and sometimes you go back to scratch. But once we've automated that, I think it will become much easier. So thank you very much. I don't know if I stop sharing here, which is probably the best thing to do. And then any questions?